Hello, my name is Lori Muffley. I am an associate professor of medicine at Stanford University. Thank you very much to the organizers for inviting me to give this talk. The title of my talk today will be Approaches to Cellular Therapy in Relapsed Refractory B-cell ALL in Adults. Here are my disclosures. So I thought it may be best to frame this discussion in the context of a case. So this will be a case that is a takeoff of a patient in my clinic. This is a 43-year-old male with Philadelphia chromosome-like negative B-cell ALL with a normal karyotype and no adverse molecular features. The patient received induction therapy with rituximab plus hyper-CVAD. He achieved a first complete remission with MRD detectable by NGS MRD at 10 to the minus 4. The NGS MRD that we most commonly use in the United States is the clonoSEQ assay. Following cycle 1, the MRD persisted through cycle 4 of our hyper-CVAD, now at a level of 10 to the minus 5. He then went on to receive 2 cycles of blinatumomab, and the result following blinatumomab was that his NGS MRD was down to 1 residual cell with his clonal IGH sequence per million examined in the bone marrow. At that point, he underwent a myeloablative matched unrelated donor allotransplant. He engrafted, had no graft versus host disease, and was tapered off immunosuppression by 5 months post-transplant. At his 6-month post-transplant disease evaluation, he was noted to have 113 residual clonal cells per million, and by flow cytometry, 0.01% B-cell ALL that expressed CD19 and CD22. So the question is, what should we do next? So in the United States, at least, we have an array of options, including chemotherapy, inotuzumab, blinatumomab, brexacaptogene autoleucel, and obicaptogene autoleucel. And today, we're speaking about cellular therapies, and so we're going to be focused on brexucel and obe-cel. So here is a figure or a table of the 3 currently commercially approved CAR T-cell therapies targeting CD19 in acute lymphoblastic leukemia. This table displays the similarities and differences, and so I will walk through each of them. So brexacaptogene autoleucel has been approved for adults 18 and older with relapsed or refractory ALL since 2021. The other name for this product is Tecartus. Obicaptogene autoleucel was approved late 2024 for adults 18 and older with relapsed refractory ALL. Anticigen leuclucel, or Kymriah, has been approved for several years now for children and adults up to the age of 25 who are in second or greater relapse. Now, I think it's important to look at the characteristics of each of these CARs because they are not the same. We'll start at the bottom. So the co-stimulatory domain, which is very important for CAR T-cell function and behavior, differs between these 3 products. You can see brexacaptogene autoleucel has a CD28 co-stimulatory domain, while obe-cel and tis-cel have 4-1BB co-stimulatory domains. The transmembrane domain and the hinge region also differ between the 3 products. And then importantly, the antigen binding domain differs. And so each of these 3 CARs binds to CD19, but FMC63, which is used most commonly in commercial CD19 CARs, is what is used in brexucel and tis-cel, whereas obe-cel has a unique CAT fast-off binder. This is a proprietary binder that differs from FMC63, and we will review this in a few slides. So I'm going to start by going over the data that led to the approval of brexucel in relapsed refractory B-cell ALL in adults. This was the ZUMA-3 clinical trial. This trial included 71 enrolled patients, of whom 55 were infused. So a relatively small sample, but certainly a novel approach, which is what allowed for the approval. And you can see here, the green stars actually, since we're basing this in a case, The green stars represent what our clinic patient, the patient I'm presenting, have in common with the ZUMA-3 population. And so the median age of the trial of treated patients was 40. The majority of patients were male. The majority of patients were white. 71% had an ECOG performance status of 1. None of these patients, importantly, at time of enrollment had CNS involvement. They were all CNS 1. Majority of them had received 3 or more prior lines of therapy, including blinatumomab, 22% inotuzumab, 42% prior allo. And then when we looked at the bone marrow, when we look at the bone marrow blasts at baseline, you can see that the majority of patients had greater than 25% bone marrow blasts when they enrolled in this trial. The Brexucel ZUMA-3 met its primary CR/CRI endpoint, as well as its secondary MRD endpoint. And so you can see here that the overall complete response or complete remission with incomplete hematologic recovery was 71%. The MRD clearance, 38 out of 39 CR/CRI patients were MRD negative by flow cytometry. And one of the important features was that patients who had a bone marrow blast percent of over 75% had a lower rate of complete response. And we've seen this in most CAR T-cell studies for ALL, where very high blast burden in the bone marrow associates with inferior response. What about the toxicities? So this is important because this CAR T-cell is a CD28 co-stimulatory domain. And as you can see, the rates of CRS were 89%. That's any grade. And that's actually, very common in CAR T cells to see fever. But the rates of neurologic events with this CAR were quite high. So 60% in the ZUMA-3. Now, when we look at grade 3/4, we see a combined 24% grade 3/4 CRS rate and 24% grade 3/4 neurologic toxicity rate, including 1 death due to neurologic toxicity. What about the follow-up? So this was the original report in the Lancet. At the time of this report, there was a median of 16 months of follow-up. You can see here on the left, the relapse-free survival, and on the right, the overall survival. Of course, not surprisingly, in purple, the patients who achieved a CR or CRI had improved median relapse-free survival of 14 months. Patients who did not achieve a CR/CRI, on the right, their overall survival was quite poor, whereas patients who did achieve a CR/CRI, at this point in time, the median overall survival was not reached. Now, the investigators did do several follow-ups of this initial 55-patient cohort. This was one of the follow-ups published a couple of years ago. At this point, when this paper came out, there was 26.8 median follow-up, 26.8 months. And you can see the 18-month relapse-free survival was now 35%. So a third of patients remained in remission and alive. However, when you look at the data and you really parse it out and look at the patients who did not receive a transplant after CAR T-cell, you see that only 6 of 39 of these patients were in CR/CRI without additional transplant. So 6 patients at this time cut. And then they actually updated their data again. And now with even further follow-up, so 38 months of median follow-up, you can see, and I've highlighted here, 4 were in ongoing remission without receiving additional transplant or anti-cancer therapy. And 6 of the 10 patients who got a subsequent transplant were alive. So, I think these are important data because this CAR gets a lot of patients into deep remission. The 1-year relapse-free survival is impressive, but there does tend to be a fall off, particularly among patients who don't get further therapy. And so now turning back to our case, just as a reminder, this is a 43-year-old male with Ph-negative ALL. He got R-hyper-CVAD, went into transplant with very low level MRD by NGS of 1 residual clonal cell per million. He received a myeloablative unrelated donor transplant, did very well, but then had an MRD CD19 positive relapse at 6 months. He underwent a T-cell collection with the plan for Brexucel. He did not receive bridging therapy because his level of disease was quite low, 0.01%. He received Flu/Cy standard dosing followed by Brexucel. He experienced grade 1 CRS and grade 3 ICANS after Brexucel, both of which resolved with steroids and tocilizumab. His day 28 disease assessment showed that he was in a complete response. His NGS MRD was now negative, and he had no detectable B cells. So the question is, what should we do next? Are we done? Is he cured? Do we need to retransplant him? Do we need to do something else? Do we have data to suggest or hint at what we should do? So I'm going to turn now to real world data. And so we have a consortium in the United States. At the time of this publication, there was approximately 30 centers, and we now have well over 40 centers participating. But this was the first publication to come from this consortium, termed the ROCA Consortium, and included 226 patients who were apheresed for standard of care Brexucel, not on clinical trials, across the United States, 211 infused. And this cohort that was published was 189 patients with at least 3 months of follow-up for patients who were alive. And so in this real-world data set, interestingly, you can see that among the patients who received Brexucel, half of them were either MRD, were in complete response, as you can see in the pink on the table on the left. Half of them were in complete response, some of whom were MRD positive, but you can also see there were 28 patients treated who were MRD negative. And this is really a practice pattern we've seen in real-world studies of CAR T cells with ALL, both in pediatrics and adult. The other interesting thing when you look on the right and you see the pink was, remember in the ZUMA-3 trial, patients had to have CNS1 disease, so no involvement. But in the real world, patients with CNS2 or 3 are actually being apheresed and receiving Brexucel. So 18% had detectable CNS ALL at the time of apheresis. So now I'll just walk you through some of the response data that we saw in this population. So among the patients treated, the CR with follow-up, the CR/CRI rate in the real world was 90%. So very, very high response rates here. 79% were MRD negative by whatever assay was used. And among those patients with CNS2 or 3 disease, interestingly, almost all of them converted to CNS1, and 12 of these patients converted from CNS2/3 to CNS1 with CAR alone, meaning they did not receive intrathecal therapy as bridging. What about the toxicity in the real world? Well, it's pretty similar to what was seen in ZUMA-3. So 84% of patients treated, despite the low disease burden at time of apheresis, experienced CRS, most of which was low-grade CRS. The bigger problem was ICANS. So you can see 56% of patients receiving Brexucel experienced ICANS, and the grade 3/4 rate of ICANS was 31%, which is a bit higher even than the clinical trial. And this was a bit surprising because, remember, a lot of these patients have very low burden disease, but these are what the data showed. Now, when we look at efficacy, this is with a median follow-up of just over a year. I'm sorry, the median progression-free survival was 9.5 months. At 12 months, 48% of patients were alive and in remission, and the median overall survival was not reached. So pretty similar to the ZUMA-3 one-year estimates. Now, we did perform a multivariable analysis, this looking at variables associated with improved progression-free survival, and we did see some important variables. So one was that age at CAR T cell did not appear to adversely impact outcome. If anything, the older adults seemed to do a bit better. Prior transplant was associated with much improved progression-free survival. And this has been seen now in a few different studies, real-world studies across the world of Brexucel, that patients who received transplant prior to CAR had better outcomes. And we hypothesized that this may have to do with T cell fitness. It may have to do with a graft versus leukemia response. And then finally, and importantly, we looked at this several ways using time varying analysis, as well as landmark analysis, which I'll show you in a moment. But we did see that the use of either transplant or tyrosine kinase inhibitor maintenance for Ph positive ALL was associated with significantly improved progression-free survival. And you can see there were some variables that showed no association that are listed at the bottom with progression-free survival. In terms of what looked to associate with inferior outcomes, prior inotuzumab and the use of bridging therapy, which has been shown in other CAR studies, and these are probably both surrogates to adverse disease biology. So we did perform a landmark analysis. We also did, as I mentioned, time varying covariate analysis, just to really try to understand the impact of transplant and TKI use. And what you can see here, when we landmarked at 2 months post-CAR and just included patients who were alive and in remission, the use of transplant was associated with a hazard ratio of 0.49, p-value 0.06 in terms of favorable PFS. TKI has a ratio of 0.25, p-value of 0.02. And then we looked at also the association of NGS MRD response to Brexucel, and you can see patients who we were interested in this particular analysis in whether the use of consolidation with transplant or TKI was really dependent on whether or not patients were MRD positive or negative post-CAR. And we saw that the use of consolidation or maintenance was improved in patients who were MRD positive post-CAR, as shown in this figure, as well as in patients who achieved an MRD negative response to CAR, really strengthening the point that with this CAR, at least, the use of consolidation or maintenance, be it transplant or TKI, seemed to associate with improved progression-free survival. So back to our case. He received Brexucel. He had grade 1 CRS. Day 28, he was in a CR, NGS MRD negative, and no B cells were detected. And we left off by saying, what should we do next? So we did talk to him about a second transplant. He declined, as do really all of my patients. I would say it's very, very uncommon for my ALL patients to be open to second transplant. So we decided that we were going to track monthly clonoSEQ MRD and B-cell aplasia from his peripheral blood. And at 4 months post-CAR, his clonoSEQ remained negative, but we did detect the recovery of normal B cells. And so is this prognostic? What does this mean? And so what we found in our real-world consortium in the United States was that NGS MRD actually, at the time that our initial publication was put together, was only used in fewer than a third of patients. So it was very difficult. That practice pattern makes it a bit difficult to understand its true impact. And we also found that there's a lack of uniform approach to monitoring for B-cell recovery post-CAR in adult ALL. However, the pediatricians do this much more frequently and much more consistently. And there's a very nice paper by the pediatric group here in Blood Cancer Discovery, really looking at these two variables, NGS MRD and B-cell aplasia. And you can see that for children who receive CAR T cells for ALL, this combination of NGS MRD and not recovering B cells, so ongoing B cell aplasia, leads to really like a 75% plateau in EFS. And this is, you can see, several months post-CAR. However, having either B cell aplasia loss or MRD coming back is associated with worse EFS. And so at least in children, it does seem like loss of B cell aplasia is significantly important. I'm going to just take a moment to talk, since we're talking about children in the pediatric group, about an analysis that was done comparing Brexucel to Kymriah or Tisacel amongst AYAs. So this is another U.S. Consortium study looking at patients between the ages of 18 and 25 who are eligible for either Brexucel or Tisacel in relapse. And so here you can see, and this was just published in Blood Advances, and here you can see one of the major findings of this study, which is looking at toxicity differences with Brexucel in blue and, with Tisacel in blue and Brexucel in red. You can see here the rates of overall CRS in AYAs was higher in Brexucel, although grade 3, 4 CRS did not differ. But really, and this is really not a huge surprise, but what differed tremendously was the rates of ICANS, both any ICANS and grade 3, 4 CRS ICANS, which were much higher in the AYAs receiving Brexucel. In terms of complete response and MRD negative complete response, there was really no substantial differences. And then in terms of survival probabilities, again, really statistically no significant differences between these two CARs. Interestingly, we did see a hint that perhaps Brexucel had a higher numerical 12-month PFS, but no statistical difference. So back to our case, our patient declined a second transplant. He did have B-cell recovery at 4 months post-CAR, but remained clonoSEQ NGS MRD negative. We did at that point, this was actually a real case, this was a couple years ago, we did decide to give him a DLI and start him on POMP maintenance. And that was in part because he had not ever received POMP maintenance because he had come to transplant. And, you know, perhaps this was luck, but it worked. This patient is now just about 2 years out from CAR. He's back to work full time. He's actually a surgeon, and he remains clonoSEQ MRD negative. So just going back to these CARs, remember this patient was treated a couple years ago. We just got obe-cel approval in the late fall in the United States. And so I'm going to spend the next couple of minutes talking about obe-cel, which was not available when this patient was treated. But I did mention that this has a unique binder called the CAT binder. And you can see here, this CAT binder is really a fast off binder. That's really the purpose of that is we know that when CARs are tonically active and signaling, we know that that increases the exhaustion rates. And in ALL, we believe to some extent that CAR persistence is important. And so the more exhausted the CARs are, the less likely they are to be persistent. And so in these preclinical studies, this particular binder was shown to have a high percent of tumor killing and really to this fast off to really curb the exhaustion and improve the proliferation and killing of CAR. And so the trial that led to the approval of obe-cel in the US was called the FELIX trial. This was a phase 1b/2 pivotal trial. And there's a few interesting things about the way that this trial was designed. The first is that as you can see, this is a split dose infusion. So this is the only CAR that I'm aware of that is given in 2 separate doses. In the trial, the first dose was on day 1 and the second dose was on day 2. I'm sorry, not on day 2, on day 10. And you can see on the bottom that actually the dosing schema was based on disease burden. And so the disease burden had a cut point at 20%. So for patients who had less than 20% bone marrow blasts at lymphodepletion, the first dose of CAR was 100 times 10 to the 6, and the second dose at day 10 was 310. Whereas for patients with higher disease burden of greater than 20%, the first dose was 10, very small dose of CAR, 10 times 10 to the 6, and the second dose was 400. And you can see that there were 3 different cohorts treated. Cohort A was really what their pivotal cohort, which was patients with morphologic disease at screening. This was all adults over the age of 18 with relapsed refractory B-ALL. I'll go through this quickly. This is just their baseline characteristics, which looks pretty similar to most of the CAR trials in adult ALL. All treated patients, N equals 127, of whom most fell into the morphologic disease cohort. You can see 74% CR/CRI rate, the majority of whom were MRD negative. And in patients in those other categories, particularly cohort B, which was MRD only, all achieved MRD negativity. The event-free survival at 12 months with obe-cel was 50%. Again, very similar actually to the Brexucel ZUMA-3 data. But here, I think, is where you see some difference, again, with toxicity. So the overall S rate with obe-cel was 69%, but only 2% had grade 3/4. And the overall ICANS rate was 23%, but only 7% had grade 3/4. Now, these data were updated with long-term follow-up, and I'm gonna just kind of keep going through. So you can see now with 36 months follow-up, you can see a very nice plateau of curves here, both for EFS and for OS, suggesting that perhaps this CAR may lead to durable remission. The majority of these patients did not receive transplant after CAR. And so that's kind of exciting for the field, thinking that perhaps this CAR may be less toxic, but also lead to durability. And there's more novel therapies coming in ALL. We have bi and tri-specific targeting of CD19 2022, novel antigen targeting for B-ALL, CD7 CARs and T-ALL, and I'm just showing some data from a company, Wugen, who just launched their pivotal trial of CD7 CAR for T-ALL in the United States, which is exciting to think that we may have eventually an approved product for this population in need. And lastly, I will just mention some work that we're doing here at Stanford, combining CAR T cells with allo transplant. And so we use a graft called ORCA-T, which is a regulatory T cell-based allogeneic transplant graft. And we add in CAR T, in this case, CAR 1922 from the donor. And so this is a bit of a complicated trial, but the donor undergoes T cell apheresis. Then they go GCSF mobilization for transplant collection. The patient, on the other hand, undergoes conditioning. On day 0, they receive the CD34 HSPCs and the regulatory T cells per the ORCA-T graft. And then on day 2, they received conventional T cells as well as CAR T cells from the donor. And one of the interesting things about this trial, we've now accrued 17 patients, is that the CARs, when obtained from the donor and given after myeloablative chemotherapy, do appear to be long-lasting. So we have 8 patients over 1 year, all with detectable CARs from the donor, which is quite interesting. So the last thing, how do I currently use CD19 CAR T cells that are commercially available in relapsed refractory adult ALL? So in adults who are transplant naive but are eligible for transplant, so if they haven't had a transplant and are getting a CAR, for patients who achieve NGS MRD CR, typically within 2 to 3 months, I am consolidating with transplant for most of these patients, although I think the obe-cel data is compelling that perhaps there will be a sizable population who can remain in deep remission without transplant. If patients had a prior transplant or are transplant ineligible and achieve a deep remission from CAR, I monitor their NGS MRD and B-cell recovery closely. If they turn NGS MRD positive, I confirm, track, and always intervene. If they remain negative for NGS MRD but have return of B cells, there's a whole array of things to consider. It's a very difficult decision. If they're Philadelphia chromosome negative, if they're pH positive, I definitely start them on a TKI. So in conclusion, since entering the US market for adult B-ALL in 2021, we have learned that Brexucel performs similarly in the real world as in ZUMA-3. There is a high rate of high-grade ICANS. However, I will say I do think we've gotten better at managing this toxicity. Cure rates with Brexucel alone in the absence of consolidation are somewhat low, but not impossible. Obe-cel entered the US market in late 2024. This CAR targets CD19, but using a different binder, a different construct, and a different co-stimulatory domain. Low rates of high-grade CAR-mediated toxicity in their pivotal trial, and cure rates with obe-cel alone in the absence of consolidation do appear promising, but require more data and a larger sample to confirm. There's ongoing opportunities and challenges with CAR T cells in adult ALL. I think improving access and cost, certainly optimizing patient selection, and then understanding ideal sequencing and timing and clinical trials are very important to understanding this. And thank you to my team. Thank you to our consortium, which has been a lot of fun to work with. And again, thank you for inviting me to give this talk today.